Do we need to manage cholesterol? This is a controversial topic these days, as it seems that there are two opposing sides. We have cardiologists who think babies are statin deficient, everybody needs to be on a statin for cholesterol management, and we have the holistic functional med providers who think nobody needs to be on a statin. So I've been trying to research and see where I want to fall in that. Honestly, I started doing research so I could justify not checking cholesterol in everybody, as it'd be one thing that I wouldn't have to talk about and wouldn't have to manage. However, there's just overwhelming amount of research and literature showing that the tighter we control your cholesterol, the less atherosclerosis, strokes, heart attacks, and overall improved lifespan from tighter cholesterol management. There doesn't even seem to be a lower number, as it just seems that lower is better. Does that mean I'm going to start everybody on a cholesterol medication? Absolutely not. And I do think both sides have valid points. The functional med providers say that as long as you're insulin sensitive, you don't need to worry about cholesterol because your insulin sensitivity is largely the driving factor in the development of strokes, heart attacks, atherosclerosis, and I don't think they're wrong. I do think being insulin sensitive is overall everybody's goal. However, a lot of an individual's cholesterol is genetically determined. No matter how perfect you eat, no matter how good your lifestyle is, some just aren't going to get beneficial numbers. There are various markers that we can check. Apolipoprotein B, particle size, LDL-C, all those are useful. I'm typically just checking LDL-C, as it is the one everybody is most familiar with and gives us a guide on what number is that. Ideally, I would like for most of the individuals to keep their LDL under 80. Does that mean if their number is 95? No, but we're gonna talk about it. I am more likely to start someone on a medication who is high risk. Who is high risk? Individuals that have already had a stroke or a heart attack, somebody who is diabetic or pre-diabetic, somebody who's smoking, somebody who has significant family history, includes heart disease in their 30s, 40s, 50s, or younger strokes or younger age strokes, or anything along those lines. What about for the healthy individual that just happens to have an LDL of 150 to 200? Should we treat that? From the research I can tell, I would say yes, try and get that to 80 or below, and it's going to decrease their lifetime risk of strokes, heart attacks, atherosclerosis. So we decide to initiate treatment. Where do we start? Statins are typically first line, and I know everybody hears statin and thinks immediately that they're poorly tolerated and that they're gonna worsen insulin sensitivity and they're gonna cause Alzheimer's and they have all these horrible side effects. In reality, a small subset of people do get side effects, but they are very well tolerated and typically the most affordable of the options. And so statins will be offered. Ezetimibe is another option. It works a bit different in that it blocks absorption from the gut. There is a small subset of people who are hypersensitive to dietary intake of cholesterol, and they do very well without ever needing a statin when I start ezetimibe on them. So that's an option. If we do start a statin, if you couple it with CoQ10 and or magnesium, a lot of times that'll help offset the potential myalgias, which is a fancy word for muscle pain. And then, of course, if you do get side effects, let us know. We'll change statins. We'll change to ezetimibe. We can stop and reassess. We can just see how you do. We will continue to monitor your cholesterol levels to make sure that you are getting a positive effect with minimal side effects. But if anything negative does arise, of course, reach out to us. Or Or if you have any questions, let us know. I'm happy to also provide the numerous studies, the human randomized control trials, the meta-analysis of all the literature, the Mendelian randomization trials. All of those are what I've been using to really solidify my action plan for lipid management.